Sociology of Health, Modern Healthcare in Dialogue with Everyone. Plenary Session. Елена Аксенова, Director of Research Institute for Healthcare Organization and Medical Management. Good morning. I'm glad to welcome you to the fourth forum with international participation, Sociology of Health. This year, we are covering a very important topic. We will discuss the issues of building various healthcare communication strategies. That being said, we understand that the healthcare system is not only a doctor-patient interaction. These are contacts with many other specialists. And not only the quality of medical care depends on them, but also the satisfaction of the population, every inhabitant of our country with medical care, and of course the health of each of us. Advancements of the medical science, emergence of new technologies, and changes in the healthcare organization model contribute to the changes in the very essence of the healthcare system, as it is becoming personalized and precise. And now we are returning to the origins of medicine, whose progress was planned and put into motion by our compatriots back in the 18th century. Our teachers are Matvey Mudrov, Sergei Botkin, Nikolai Simashko. All of them are great doctors, scientists, healthcare organizers, who always taught their students that it is not a specific disease that needs to be treated, but a person, the person as a whole. Today, the development of digital technologies allows us to move to a personalized model of medicine, and to really treat and study not just a single disease, but the whole person and their health. Now we're closer than ever to what is health, to management of personal health and population health. And today we shall also discuss all of this. This forum is a unique discussion platform that brings together sociologists, psychologists, doctors and healthcare organizers, and even marketers, economists and educators. All these people are involved in creation of a new healthcare system and transformation of the healthcare organization model. The forum will be very interesting and eventful. As usual, we will have a plenary session, 5 sections, and we'll finish off the day with summing up the results of the forum and another very important event. It has already become a tradition that our forum organizes and hosts a competition for young researchers in medical sociology. This year was not an exception. Until October the 10th, we gathered the work results of our young researchers from all over Russia. After that, we have several meetings with them, we select the best projects, and today we are ready to name the winners and present their work. In the evening, we will announce the winners after the business program is over. I would like to remind you that as always, we have a tight schedule. The plenary session will take an hour and a half, and many esteemed speakers and experts will take part in it. I will introduce them in the course of their reports, and every speaker will have up to 15 minutes. I really hope that we will not exceed the allotted time. After the plenary session, we will have 5 sections in succession. As I have already said, the sessions will have an intense program and tight schedule and feature interesting speakers. I would like to introduce the main organizers and our partners of the event. The forum is organized with the support of Moscow Healthcare Department. Our Research Institute for Healthcare Organization and Medical Management is the main organizer. And we are partnered with the Russian Academy of Sciences and the Semashko National Research Institute of Public Health. Colleagues, more than 3,000 participants have already joined us. We will have 30 experts presenting their reports. And I wish us all fruitful work and good luck at our event. I remind you that the forum is held with the support of the Accreditation Committee, so all participants who make it until the end of the event and watch the business program in full will be awarded credits of continuous medical education. Well, now I propose to move on to the reports so as not to waste our time. And I invite the first speaker to our studio. I present to you Ignat Bogdan, head of the Center for Medical and Sociological Research of the Research Institute for Healthcare Organization and Medical Management. Ignat has been the head of the center since its inception, from the day it was founded. We have a very unique center and the largest center in Russia today that is engaged in medical and sociological research. This center annually conducts more than 30 large-scale sociological studies. The sample size is large and includes various categories: patients, residents of Moscow, residents of the regions of Russia who engage with the healthcare system and decide to receive medical care in Moscow, foreigners who live in Russia, and of course, doctors, nurses, and healthcare organizers. The center specializes in research on the public satisfaction with medical care and issues related to health workers' loyalty to the healthcare system. We study the image of doctors and nurses in the modern healthcare system. So the center does a lot of interesting research, produces a large number of publications, and takes part in different events. Ignat is also a WHO expert on behavioral models in the healthcare system. As one can tell, we have a few things to share with the framework of this forum. So in our first report, Ignat will share the achievements of the Institute and the Center for Medical and Sociological Research that have taken place this year, and we'll talk about the methods of organizing sociological research that we use to describe what the healthcare looks like from the point of view of the patient and the doctor. Ignat Bogdan, head of the Center for Medical and Sociological Research at the Research Institute for Healthcare Organization and Medical Management. Good afternoon, dear colleagues. Good afternoon, Yelena. My report is called Some Aspects of Building a Dialogue at the Level of Medical Organizations. Today, our forum is primarily dedicated to dialogue, and from our point of view, it is impossible to build a quality healthcare system without dialogue. When we talk about dialogue, first of all, we consider socio-humanistic knowledge, because this is primarily an area of dialogue. This is an area of competence of such sciences as sociology, social psychology, and other socio-humanistic sciences. And in my report, I would like to focus primarily on the practices of socio-humanistic knowledge in medical organizations and the value transformations that are necessary for their implementation. In general, the theme of the dialogue itself is very broad, boundless even, so in my report I would like to cover a small portion of this subject. We can look at the dialogue at the macro, meso, and micro level. So I would like to focus on the meso level, meaning at the level of individual medical organizations. This is the level of interaction between representatives of the healthcare system and patients, and this is the level of interaction between doctors between chief physician and medical staff. Since, for the most part, we specialize in Moscow healthcare, in my report I will primarily rely on research data in the Moscow region. On the slide, you can see the data of our survey. Almost 40% of medical organizations of the target audience were surveyed, and each organization accounted for more than 2 reports. This means that more than one person could answer from each organization from different departments, but on average more than 2 people answered. We collected data on the practices of working with feedback and the practices of implementing surveys. If we look at the data, we see that not all medical organizations actually admit that they do this kind of research. In fact, this statement is false because all organizations in fact engage in independent evaluation of services and processing feedback from patients. But according to the survey, not everyone thinks that they are involved. And in fact, this is the discrepancy between the survey data and the objective data. It can be a source of certain valuable information. What does this tell us? The reason for such a discrepancy may be at the level of concepts, that is, not all people believe that they work with feedback, or they do not consider the work with feedback that they carry out to be as such. For example, with regard to independent evaluation of services, not all medical organizations, not all responsible officers from medical organizations get access to this data, and that is why some responsible officers believe that they conduct survey studies and some believe that they do not. The second important reason is that some representatives of the organizations are unaware of the ongoing research. Our data show that 20% of organization representatives do not know that their organizations have conducted such studies, even though such studies were definitely carried out before. The third reason is the lack of centralization, because often such studies are scattered among different departments. And the fourth reason for possible distortions is the potential bias of the sample in favor of the more vocal people. That is, organizations more involved in social service were more ready to talk about this topic. In fact, here we see a certain value bias. Let's take a closer look at certain feedback practices. We will start with feedback from representatives of the medical community. That is, how medical organizations work with feedback from employees. And we see that respondents in more than half of the organizations think that such communication exists. First of all, through questionnaires and interviews with employees. If questionnaires and interviews are fairly understandable methods, then the use of focus groups and in-depth interviews raises a number of questions. Our experience shows that not all representatives of medical organizations understand what in-depth interviews are, what focus groups are. For example, a very common request from representatives is to add answer options to the focus group guide. Those who know what a focus group is understand that this is a dialogue script and there are no fixed answer options or closed-ended questions. What is important is that the collection of information from employees, that these initiatives often represent internal corporate requests. However, external requests from the Ministry of Health and other regulators occur quite rarely, and the issue of methodological support in conducting employee surveys becomes very clear. Our institute is actively involved in this, and last year, for example, we issued guidelines on how to work with loyalty in medical organizations. As for patient surveys, we see that 77% of responsible officers agreed that organizations do conduct patient surveys, and these studies are initiated by the regulatory authorities, like Moscow Healthcare Department or the Ministry of Health of Russia. So, on the one hand, such processes are well standardized in terms of survey tools. That is, we have a single questionnaire with which we can obtain comparable data on the subject level and on the country level. On the other hand, there is a serious issue of methodological standardization, because unfortunately myths are still widespread in the expert community about, for example, what a good representative sample is, that it is necessary to interview 10% or 5% of people, this will be representative, or they use random sampling formula incorrectly. And in our methodological recommendations, in our expert speeches, we do try our best to expose such myths in the hope that the professional community will also be more actively involved in exposing such myths, because if you do not follow the methodology, often, as our research shows, it produces overestimated results. And when a manager receives overestimated results, they can make incorrect decisions. Therefore, this issue is extremely important for health management. And I also want to note that the methodological influence of regulators is very visible at the level of tools, at the level of survey data. For example, the most common toolkit for collecting data from employees was scale questions. Since some kind of psychological scale are often used, like rate your satisfaction from 1 to 5. But at the patient level, the first choice of tools are textual questions, for example, to evaluate satisfaction from completely satisfied to completely dissatisfied. And here we see that such a strong methodological influence of standardized questions, since mostly textual questions are used in standardized questionnaires. To sum up certain results, I would like to highlight first of all the challenges, and then I would like to highlight the trends. And the first thing about challenges. The most important challenge is the lack of methodological knowledge for conducting sociological surveys. But we understand that the staff structure of medical organization does not provide for a medical sociologist, but in principle there is probably no need for it. Those who have to conduct opinion polls, especially if it is some kind of private initiative, more often than not they are psychologists or social workers, who do not precisely know how to conduct a sociological survey. Well, we can also say that not all sociologists have applied skills in conducting opinion polls. So, of course, there is a serious question of who should conduct these studies. That sort of situation often leads to the lack of motivation to conduct surveys. That is, responsible officers in medical organizations are not motivated either financially or fundamentally because they do not understand what they are doing. They do not see the results, as often the end results are not brought to their knowledge. So all this leads to discrediting sociology as an unnecessary and some kind of mere formality, which we would like to avoid. The third challenge is the lack of centralization for collecting this kind of information. I have already said that the collection and processing of information can be split among different departments of the organization, especially when they have many branches, and this all results in the organization not sharing the best practices within itself, that is, each department can exist and work autonomously. And finally, this is the challenge I was talking about, the lack of standardized qualitative methods for collecting feedback, meaning how to properly conduct brainstorming sessions, in-depth interviews, and focus groups. Unfortunately, medical workers often do not understand how to do this type of work, and in principle they should not know how to do this. They were not taught this, it is not their primary function. But this is a very important methodological aspect. Finishing with challenges, we move on to trends. I also wanted to highlight several trends. The first one is humanistic tools are widely used in studies of medical organizations of Moscow Healthcare Department. This is partly a necessity because we are required to conduct opinion polls. The studies are often initiated by psychological departments and social work departments. Second trend is regulatory bodies often act as initiators of standardization in feedback collection, and we must take this into consideration. That is, there are standardized questionnaires, but often there is not enough standardization of survey methods, and must certainly pay more attention to this. Third trend, our respondents say that today humanistic methods in healthcare have a pronounced practical effect both for employees of medical organizations and for working with patients. These methods are used to motivate employees to improve some processes in their organization concerning scientific work. And finally, some of the existing challenges and trends indicate the urgent need to create a unified methodological centers of competence in socio-humanistic health research. And in particular, our division considers methodological support of this kind of research one of our missions. Our center is already doing this today. And to conclude my report, it seems that a certain value shift is needed to introduce a positive trend in healthcare. The first is to recognize the real necessity of socio-humanistic knowledge in healthcare. And in this aspect, we see certain positive development. The World Healthcare Organization also recognizes this. In recent years, they have created a division of so-called cultural and behavioral insights that actively promote socio-humanistic knowledge in healthcare. And we in Moscow are conducting our research using WHO methodology and are actively cooperating with WHO on this issue. Well, we can say that our forum is partly a platform that promotes socio-humanistic knowledge, and we plan to create other expert platforms. The second value shift is readiness for dialogue. That is, when the parties perceive each other as partners and not as enemies, meaning when someone likes feedback, they say that it is good, and when they do not like it, they dismiss it as incompetent. It shouldn't be like that. The parties must see each other as partners. Of course, there are some serious issues when unscrupulous actors begin to interfere in this dialogue, when there are certain fakes. Well, this is a serious methodological challenge, and communication with patients and employees in social media is very important from this point of view. And this year, our center just created a rating of medical organizations in terms of the quality of interaction with patients. And one of the most important criteria was feedback process and how well it is organized. This was one of the most important ranking criteria. And finally, the last third point is value unity. The parties in the dialogue should have a certain value unity. That is, we have the most common value among the population, the values of social justice, of state social concern for the population. Accordingly, a dialogue should be built from these points. Communication campaigns should be built from these foundations. In general, friends, I would like to say that today we must be united. We must work together within the healthcare system, and only by joint efforts we can create an excellent healthcare of the future. Today is the time of the collective effort. Today no one is an island, and the best player in the healthcare system today is a team player. Thank you very much, dear colleagues. Thank you, Ignat. I would like our participants to notice that the attitude towards feedback has been really changing at national and regional levels in the last 3 or 4 years. The executive authority seeks to use this tool for developing sociological research as the main tool for studying feedback from various categories of the population. But we are witnessing that it is before everyone was an armchair in medicine, then education, then now everyone is an expert in sociological research. There are some risks though. The sociological research is just a formality if doctors and other medical specialists are engaged in non-core activities. Thus, we cannot evaluate the adequacy of feedback received from potential patients or people who have already visited a medical organization. That's why the decisions of healthcare management are influenced by sociology, numbers, and trends from these sociological researches. So, as professionals, we must remind the healthcare managers at different levels that the methodology of social and human studies should be knowledge-intensive and created by specialists. Then, the feedback results from sociological researches must be objective and must adequately describe the situation at a given territory or medical organization. Our Research Institute for Healthcare Organization and Medical Management always supports the elaboration of the resources and knowledge bases for medical specialists. So the Institute's Center for Medical and Sociological Research acts as a methodologist in different sociological studies carried out at the medical organizations. We freely share instruments and tools developed on our own with all colleagues from Moscow medical organizations and other scientific and applied research centers at regional level. So we would be glad to help your organization to create a correct framework for sociological research in the healthcare. Before we invite our next speaker, I would like to emphasize that the healthcare system becomes primarily patient-centered. This may be the core of healthcare transformation in recent years. It changes not only in Russia, but the whole world starts to treat a person as the center, the heart of the system, surrounded by all healthcare models and structures, as well as organizations of diagnostics, treatment, and prevention of diseases. Moscow was probably one of the first metropolitan cities to develop such patient-oriented model of the healthcare system. The earliest projects were carried out in the middle of 2000s in Moscow. Now there are numerous projects, numerous specialists who comprehend the patient-centered model of healthcare and know how to implement it. Andrei Tizhelnikov is one of the leaders of modern patient-centered healthcare system. He is the chief specialist of the Moscow Healthcare Department in Primary Medical Care and the chief physician of Polyclinic number 121. He is a person who takes on all of the most difficult person-oriented projects in Moscow, given his professional skills, intelligence, and proactive attitude. For example, the telemedicine center was opened with his help during the COVID-19 pandemic. Moscow has increased not just by dozen, but by a millionth time the number of consultations in this telemedicine center for patients. He is a person who systematically evaluates the satisfaction with healthcare quality in Moscow hospitals. He actively supports the professional development of his colleagues and closely monitors the emotional burnout and the career building of his employees. So, Andrei, please, the floor is yours. Andrei Tizhelnikov, Chief Specialist in Primary Medical Care, Chief Physician of the Consultative and Diagnostic Center number 121. Good afternoon, dear colleagues. I greatly appreciate the chance to participate in the annual Forum Sociology of Health. Nowadays, it seems impossible to develop the primary medical care, to provide and organize in general the healthcare services without various sociological tools. I would like to tell more about those tools that we use or could use, notably in primary care. So, sociological research in primary medical care provided to the adult population. Firstly, it is important to say that the current key trend definitely changed the healthcare system, if not every day, then every month. and this influence should be always followed up by various sociological studies. Of course, we also see the transformation of patients. They become more informed and involved in treatment. They make high demands on quality of provided healthcare services, as well as on communication. Beside that, we observe some negative trends, an excessive adherence to different sources of information, as the internet or second opinion from other medical organizations, and a low engagement in treatment or self-treatment, which is self-prescribed following these online searches, and finally, over-worrying and hypochondria. I would like to emphasize that doctors change too. They become more dynamic and involved in work processes, not only at their own workplace, but at the level of the whole medical organization. By the way, the heads of medical organizations have faced the necessity to adequately manage and new access to information. We use several principal instruments for sociological research on a daily basis. It is mainly sociological and hygienic or medical and sociological studies, conducted directly with patients or doctors by means of survey, questionnaires, different analysis of databases, or primary medical communications. Of course, we also study different products and projects carried out today in the healthcare system. For example, describing value chain and mapping patient pathways. I would like to present some projects that we have realized in the last year with our colleagues from other medical organizations. One of these studies was performed this year in cooperation with the Department of Public Health and Healthcare of Pirogov Russian National Research Medical University. The study analyzed the sociological and hygienic image of citizens vaccinated from COVID-19. It is important that this data set, the basis for developing the models that we use to organize the big centers for mass vaccination, such as GUM and Гостиный двор, and the small ones at other public places. In 2021, we conducted another interesting study with the help of the organizational and methodological divisions for primary healthcare. It was a comparative analysis of COVID-19 patients' satisfaction with medical care provided in the telemedicine center. It is also important to notice that this study allowed to apply more effectively speech models and templates for filling out medical records. In addition, the studies are devoted not only to patients, but also to doctors. In 2020, together with the Center for Primary Health Care, we conducted studies on the professional burnout of doctors who provided telemedicine consultations. These studies allowed to improve telemedicine consultations at the Telemedicine Center of Moscow Healthcare Department. Another study defined the level of employee motivation. It was performed in cooperation with the National Institute for Quality of the Federal Service for Surveillance in Healthcare in 2019. The results allowed us to elaborate several algorithms for motivation that we use in our organization today. Finally, together with the Organizational and Methodological Division for Primary Health Care, we did an interesting study on the evaluation of employee engagement in processes for providing medical care or in the processes associated with organization of activities, including organization of spaces. It is crucial to note that the study resulted in increasing the employee motivation and in changing some procedures of the organization. So, it is worth to say that all social, sociological, and hygienic or sociological researches performed in the organization really allow us to make the medical organization and the processes of medical care provision more patient-centered and patient-oriented. That's why all changes that we implement in our medical organization anyway require the constant follow-up by different surveys, questionnaires, analysis of medical records, and analysis of big data in order to correctly and timely evaluate the quality of these changes, to evaluate the need to make the adjustments in some or other processes. Thank you for your attention. I would like to thank again the forum managers for constant and continuous improvement of us healthcare workers. I would like to wish everyone who attends the forum and is interested in sociology of health to apply this knowledge in practice and to work productively. Andrei, thank you for this very interesting presentation. The issues of patient orientation in the Moscow healthcare system are on the table and are actively discussed at the medical organization level as well as at the city level. Dear colleagues, we're moving on to the next speakers. We have some interesting presentations about healthcare systems, doctors, and patients. Our next speaker is Elena Udalova, Head of Sociology Department of ANO Dialogue. As you may remember, about 4 years ago, the Dialogue company was founded, and its goal was to obtain reliable, high-quality feedback on the activities of regional executive authorities. This organization collects, accumulates, systemizes, structures, and uses data in order to build a social state. Elena studies sociology, various behavioral models of population, including healthcare data, as well as analyzes the most effective communication relations for interaction with population groups, and finds out the easiest and most effective ways to build an open dialogue between people and the government. And some studies are related to health. These studies are mostly of federal significance. In other words, they were held in different regions. And we would like to know how people assess their health now, how healthy they feel, and what else they would like to change in order to provide them with medical care instead of medical service. Elena, the floor is yours. Elena Udalova, Head of Online Sociology Department of ANO Dialogue. Good afternoon, dear participants and experts. The fourth Forum Sociology of Health, Modern Healthcare in Dialogue with Everyone, supports the general trend, which is now important for the whole country, and its focus on customer centricity. Healthcare, as one of the main sectors, also takes up this trend and becomes even more patient-oriented, client-oriented and human-oriented. Despite the fact that our organization collects feedback and receives complaints and appeals from citizens on various topics, including healthcare, I would like to discuss a slightly different issue today. I think that such a feedback aimed at creating a dialogue is not only based on complaints about specific services, but also helps to understand how healthcare assess health categories and how people assess these health categories, as the whole healthcare sector is focused on maintaining and preserving health. In my opinion, on the shared perception of contribution of medicine to health and public attitude can allow us to build a dialogue and achieve our goals and objectives. Therefore, I would like to tell you a little more about results of our research. We interviewed 5,000 Russians on the subject of the concept of healthy lifestyle and health, and asked them whether they maintain a healthy lifestyle and how they assess their lifestyle. 7.4 points out of 10 respondents assessed as the importance of healthy lifestyle. 61% consider their lifestyle to be healthy. The proportion is higher among respondents over the age of 60. But it's necessary to note that all the respondents are highly recommended to maintain a healthy lifestyle. In order to maintain health, you need to visit a doctor and adhere to their recommendations. Also, high-income citizens tend to maintain a healthier lifestyle. Firstly, it is related to a trend for a healthy lifestyle. Secondly, they have better financial opportunities. Many of them are highly educated and are focused on improving their quality of life. Women traditionally tend to care more about their health compared to men. So, health and medicine. How are they connected in people's minds? Do they help? To what extent investments in medicine and quality of services influence patients' opinion about healthcare services? What factors influencing health are the most significant according to patients? We offered them several questions and suggested to determine whether this factor affects their health or not. The first place was stress as the most significant factor. 78% of respondents believe that it has a major effect on their health. The second place share sleep and rest. However, only half of the respondents say that regular medical care plays a significant role in maintaining health. And the opinions are polarized. Almost a half of respondents believe that it helps, and the other half thinks it has no impact. We can observe a certain trend here. People think that our healthcare is being formed only in an emergency situation. We are used to see a doctor only when feeling sick and being in need of an emergency medical help. At the same time, we underestimate preventive diagnosis. While doctors rely on it, highlight its importance and remind about its significance in maintaining health. There are different ways to improve mood, which most correlate with previous indicators. Enough sleep, communication with family, walking, smoking cessation, and no alcohol consumption are also considered effective. That is, according to people's opinion, factors that improve mood and factors that improve health are practically the same. What do people consider healthy lifestyle practices? The top 3 health habits include smoking cessation, good sleep habits, walking and hiking. At the same time, only 30% of respondents say that it is necessary to undergo routine medical examinations. There are also very controversial answers, such as outdoor activities, hot baths and saunas, and even a few answers about vitamins, which cannot be taken without doctors' prescriptions, and doctors are against that. Therefore, we can see that the public perception and public expectations do not correspond to healthcare and medicine contribution, preventive approach, and diagnostics. In conclusion, I would like to focus your attention on the fact that it is necessary to fill the gap between public perception and contribution of various factors in health, medicine, and healthcare, and identify what healthcare sector can offer to population in order to strengthen dialogue and therefore create mutually beneficial conditions from both the result and the process of interaction. Thank you for your attention. Liana, thank you for your interesting presentation, and we're moving on to the next speaker. It is Kirill Rodin, Director for Relations with Government Bodies, ЦИОМ, member of the Public Council of the Ministry of Health of the Russian Federation. Kirill has been dealing with issues of sociology, as well as sociology and healthcare system for many years. ЦИОМ has a large database of various large-scale sociological studies related to positioning of the Russian healthcare system and assessing population satisfaction with the healthcare system. I know that you have conducted a number of studies related to the characteristics of patients who visit medical organizations. What are they satisfied with? What are they dissatisfied with? What would they like to change in the healthcare system? Could you briefly explain it upon the results of your study? Kirill Rodin, Director for Relations with Government Bodies, ЦИОМ. Well, I would like to make a little remark. I have already left the Public Council, but I definitely support it. Well, let's start our presentation. We have done research, and then I will try to answer some questions that you've asked. Well, here is the research I would like to present now. It was focused on 3 points that, in my opinion, are comprehensive and interesting for today's discussion. Firstly, this is how people generally assess the current state of the healthcare system in terms of quality of provided services. The second point is how do people assess the potential of the healthcare system? That is, are we ready for a breakthrough or are we waiting for some breaking point? And the third point is also interesting to highlight. If we decide to make a breakthrough, in which direction should we move forward from the customer's point of view? So, if we look at the slides, here they are. So, the data were obtained upon the poll results of the population of the Russian Federation aged 18 plus with an error of 2.5%. Now, we can find out the opinion of the Russian population. So, the first question. We asked respondents whether they visited federal, departmental, or private medical organizations in order to understand who we are interviewing. So, what was the scope of this? Was it federal districts or not? Yes, all of them, the whole Russian Federation, except maybe for the territories that have joined us lately. So yes, the whole country. Well, according to the data obtained this year, we see that a third of respondents did not seek medical help. That is, the rest of the audience answers the questions relying on their own experience. Then, we asked the population our main question: are you mostly satisfied or dissatisfied with the medical care provided to you in state or municipal medical institutions? The question was addressed to those who visited these medical organizations and can recall their last visit. From my point of view, our figures are very optimistic. Well, despite the fact that 11% of respondents are completely dissatisfied and 12% are mostly dissatisfied. Firstly, 49% of respondents told us that they were completely satisfied or mostly satisfied. And this percentage, in comparison with recent years, I'd say that it is a great achievement. Considering that it was a period when the healthcare system was experiencing a so-called stress test related to COVID-19 and other challenges we faced at the time. An impressive result. And even in these conditions, we see that the estimates are still growing. Well, according to our sociology snapshot, someone is satisfied with something or dissatisfied with something. But if we're going to compare these estimates with global medical systems, then believe me, you will be surprised by high assessment of medical services here and high quality of medical care. The second question. What is the situation now in the Russian healthcare? How can we describe it? The respondents were offered the following options: not developing, catching up with global medicine in all areas, better than global medicine in some areas, no answer. Well, most of us believe that the system is not moving forward. It means that some results mentioned above have been achieved, but there is no fast movement or breakthrough, as well as a continuing trend is not observed. Well, it's not bad either. Well, 21% of respondents said that our healthcare is catching up with global medicine. Thus, we can mention that our healthcare is modernizing and dealing with backlog. And 13% of respondents told us that it is better than global medicine in some areas. That is how Russian population assess the potential of the Russian healthcare system. Well, we're running out of time, right? If you want to get access to the presentation and have a closer look at the figures, you may contact the forum organizers. So to get access to the data, figures, everything. And the third question. Well, if we decide to make a breakthrough, in which direction should we move forward, right? I'm not going to read out the question. As you can see, the overwhelming majority of respondents, that is 62%, say that the search of cancer treatment is the first indicator of a breakthrough. This is the top issue that concerns our public, our patients. Of course, this issue is related to our information policy. But nevertheless, that's what we have here. Well, 40% of respondents think that high-tech medical equipment is also important. And of course, issues related to high-tech medical care. Third place, 29% mentioned virology as the key issue. Another 20% mentioned transplantology. And on the fifth place is the fight against aging, an interesting result. By the way, it is interesting that the fight against aging is in the top 5, and I think that active longevity comes to the top of the agenda today. It is actively discussed by the population, public organizations, and the third sector. Indeed, this topic gets more and more popular today. And the population is also popularizing this agenda. Well, we're going to move on from this issue. You can analyze focus points in public requests. You may have a closer look at these figures later. And so, As I promised, I'm going to answer the question you asked me in the beginning of our discussion. I would frame this question this way: how will people understand whether they received a quality service and if they were satisfied with it? According to our research experience, there are two very important factors. The first factor is the relationship between doctor and patient. In most cases, a patient who does not have appropriate education and qualification cannot assess the effectiveness of the service provided objectively. Therefore, doctor-patient relationship is in the first place. When grannies come to their physicians with pies, cakes, and other home cooking, this is their attitude, this is their life. They are happy with how the polyclinic works, and accordingly, doctors are happy with their patients. The second point is really connected to the questions of how effectively a service was provided. We cannot move forward without understanding this. And these are the two reference points that people ultimately focus on. And of course, public opinion is related to the whole variety of social networks, mass media, word of mouth, and finally, it looks like a melting pot of different opinions. However, the process can definitely be taken under control. As I said in the beginning, from my point of view, the Russian healthcare system has perfectly passed the test, and it has shown its resilience during the pandemic period to critics, to so-called couch experts and analysts. So this is the first important point. And the second point is connected with potential obtained by the system during the pandemic. I hope that this boost will reveal itself in the near future. And not only the attitude of Russians and public opinion will be better, but the system itself, unfortunately, will still have some challenges. So, like this. Thank you for these interesting sociological figures, Kirill. I would like to ask you a few questions. You have been studying the attitude of the population to the health for many years. What do you think, on average, is our population ready to take responsibility for their health and participate in the treatment plans and prevention? Well, probably we're looking forward in this direction. Although the pandemic significantly influenced public attitude to personal health, from my point of view, we did not achieve that critical point yet. Probably it's one of these changes people expected from the pandemic. Well, thank God they started to wash their hands before eating. This is already a breakthrough. But unfortunately, there were no fundamental changes in one of the most important areas, that is disease prevention. Unfortunately, we do not see a breakthrough here. People seek medical help only in emergency and do not think about prevention when everything is fine. So, well, this is my personal expert opinion. Unfortunately, we do not see a significant change in values in relation to health. We bought horizontal bars to do sports and home during the pandemic, and now our clothes, such as leggings, jackets, and shirts, hang on them. But our population ignores the most important fact. We should start to take care of personal health starting with the youngest cohorts, as we say when speaking about young people, in the age of 30 to 40. That is the age when the first chronic disease appears and the person begins to visit polyclinic regularly. That's the turning point when we start to take care of our health. But there is no public intention to postpone this moment when the chronic disease appears. No transformation has been made yet, but we really hope for it. From your point of view, as an expert sociologist, what is the trigger that drives a person towards taking responsibility for their health? Diagnosis. Diagnosis. Yes, diagnosis, especially a fatal one. Well, there is some irony here, of course. It should be noted that, according to retrospective data since the 1990s, we always say that the attitude of young population related to maintaining a healthy lifestyle has changed. At least, it is popular now. Perhaps we not always understand the real motivation for a healthy lifestyle. And everyone has a personal model, vision, scheme, but at least it is really on the agenda. Let's live like this and live a healthy lifestyle. Well, as I say, people perceive things differently, but it is good that the topic is already on the agenda. It's not bad already. I totally agree with you, Kirill. Thank you for your presentation and answers as well as your expert opinion. And we move on to our next speaker. This is Irina Gildebrand, Director of Strategic Projects at NAFI. And we will continue to discuss behavioral trends of the population. What are these trends now? What tools can we use to measure them? And what can we do as a healthcare system to strengthen a person's desire to manage personal health? Irina Hildebrand, Head of Strategic Project of NAFI. Good afternoon, dear participants, experts, and listeners. Thank you for the opportunity to share my opinion today. Let me tell you a bit about our analytical center. For almost 20 years, we have been engaged in a wide range of sociological research. And such topics as health, self-preservation behavior, and reproductive behavior are among key topics for our research. Why are we making such detailed researches? Because we are sure that data, valid, well-collected data, and relevant analytics are the basis for effective decision-making. When we have specific figures, the situation becomes much more understandable, transparent, and accordingly it is much easier to change it. And now I would like to share with you our latest data on the topics we discuss here today. The topic is important, and our research is all Russian, so we can say that this is the opinion of all Russian people. So, first of all, the result of our research demonstrate that health and the sense of security associated with it is one of the key and basic values of Russian population. And health is included, as you can see, in the top 5 factors that influence, among other things, a person's feeling of happiness. But at the same time, there is a small gap and dissonance between what is important to a person, what he declares to be important, and what he does to ensure that these important things and values are present in his life. We asked respondents to assess how much time they spend on taking care of themselves and their health. Unfortunately, most of them admit that they devote little time to themselves and health practices. Let's cover this in more detail. There is a number of factors that can negatively affect human health. and day-to-day basis, we can say a fairly large portion of Russians face them. These factors are lack of systemic healthcare, various bad habits, irregular working hours, bad nutrition, and so on. And in our opinion, Russians of the most economically active age, that is 35 to 54, are in the risk group. Unfortunately, according to our study, they pay less attention to their health. They undergo preventive medical examinations rarer than other age categories and groups, work more, experience more stress. In general, we can say that such systemic care about health and disease prevention is still not enough popular among the majority of Russians. Moreover, there is a stereotype that living healthy is hard and expensive. But I think it's important to persuade people that a healthy lifestyle doesn't mean that you need an annual gym membership or have avocado and sprouted wheat for breakfast. But there are much easier ways to maintain your health, both physical and emotional. You can start with a routine checkup at the nearest polyclinic, maintain work and rest balance, and, for example, build strong and stable emotional relationship with your loved ones, which is also important. Taking into account modern trends and transition of domestic medicine from reactive to proactive stage, when prevention and early detection of diseases becomes key tasks. And of course, in this case, the role of medical examination increases and becomes the key tool for monitoring health indicators. In my opinion, it is necessary to take into account not only the efforts that the healthcare system makes as a provider, but also public willingness, self-understanding of the need to systematically monitor and evaluate personal health. Despite the fact that medical examination is free and there are many motivating social programs, according to our data, every fourth Russian ignores medical examination. People do not want to undergo the examination or don't do it on time, and every 10th Russian in the age of 18 and over has never applied for this service. Most often it is ignored by younger people at the age of 25 to 34. Taking into account the data and the answers obtained, explaining the reason for refusing medical examination, many respondents say that they have had no complaints or pronounced diseases. That is, the majority of Russians do not fully understand the general meaning of medical examination. That is not the treatment of the existing medical conditions, but preventive disease detection and prevention of further. I think that it is a direct message to those who are engaged in the development of communication campaigns to inform population about the importance of medical examination. And I think that we need to start with basic educational program. First of all, we need to explain the general meaning of medical examination. As for the commercial side of healthcare and paid checkups, despite the fact that it is considered to be more convenient and comfortable service, a flexible version of examination, awareness among Russians is very low here too. Only 6% of our citizens understand its meaning well, and about the same number of people make checkup visits. So a group of those who know and use such services is quite isolated and consists of young people, people with higher education, people with high incomes and residents of big cities. Accordingly, public awareness and motivation activities should be focused on these social demographic groups to increase their motivation and undergo such service. And I want to mention another trend of modern healthcare. This is telemedicine. We asked Russians about their opinion and their experience of using such services. We can say that the current demand for telemedicine services is quite high. 80% of respondents are ready to use such services, and moreover, the level of readiness is noticeably growing. Compared to 2017, this indicator has increased by 19 percentage points. Moreover, the proportion of those who have already applied for such services is growing, respectively, and telemedicine services are more popular among young people. And, of course, when speaking about such modern patterns of self-preservation behavior, we should mention the topic that we have already stressed several times today. These trends are caused by COVID-19 pandemic. In our opinion, the epidemiological situation has certainly formed new habits, including social hygiene. Of course, some habits emerged as a result of external official rules and restrictions, and some due to personal understanding of the role of each person, each citizen in maintaining public health. And we see that the Russians have begun to understand medical issues better and read medical literature independently, engage in self-education in this area. And the main achievement is that many sustainable practices and a more conscious attitude towards themselves, as well as a better sense of responsibility for the health of another person, appeared. And we choose the readiness to wear a mask in the public when the first sign of a cold appear as the main indicator of conscious attitude. And the difference between pre-COVID and the new data is significant. Only 15% of citizens were ready to put on a mask in such a situation before the pandemic, and now 70% of them are ready to put on a mask. I think the news are very promising, very joyful for us. And the current socio-economic situation highly affected human health, especially psychological health and emotional health. According to our data from this spring, the majority of Russians spoke about changes in their emotional state associated with the increase in stress and anxiety. And the majority of citizens told about changes in new socio-economic situation. For example, many people say that they work harder for more hours, spend time in social networks, and communicate differently with loved ones. And I would like to say that in our opinion, it is very important to stay informed and have up-to-date data on how the way of life of the Russian citizens is changing in connection with current conditions. For example, daily habits significantly affect human health. Understanding the ongoing transformation and the way of life can help the healthcare system to solve emergent problems in a much better and effective way, as well as adequately respond to the public demand. And in this matter, we as researchers are ready to work together, ready to share data and information, and jointly solve problems of studying and analyzing the current situation. Thank you. Irina, thank you for your presentation. Very interesting figures. Your presentation confirms that the idea we need to combine the efforts of sociologists by creating a single platform for collecting the results of sociological research. Everyone is conducting a lot of studies now. We did a joint study with the World Health Organization from 2019 to 2021. We studied similar questions. I would like to mention that more than 80% of population were ready to wear masks during the peak period of pandemic. There is a slight decrease in numbers, but the demand for the masks remains steady. Thank you, Irina. And now I would like to invite a foreign speaker. This is a representative of India, Professor Sujata, from the Center for the Study of Social Systems of the Nehru University. Her presentation is about sociological researches in India, how the results are used to transform the healthcare system, and what mechanisms of healthcare transformation use feedback from the population. The floor is yours. Dear Sujata, Professor, Center for the Study of Social System, Jawaharlal Nehru University.
Hello everyone, I am Sujata. I am a professor of sociology at Jawaharlal Nehru University, New Delhi, India, and I am very pleased to be part of this panel on human-centered values in the healthcare bureaucracy. And it's a timely and most appropriate theme, especially after the pandemic. And my presentation in this panel is on humanism and the healthcare bureaucracy, dealing with asymmetry and inequality in health communication. In my view, there are two major challenges faced by the modern healthcare system. They are asymmetry in the knowledge of the doctor and the patient. Secondly, inequality in the socioeconomic status of the doctor and the patient. That is the gap in the socioeconomic status between the doctor and the patient. So in this presentation, which will be divided in three parts, I will engage a little bit with these two major challenges, dwell on the approaches and philosophy of medicine that have responded to the problem of humanism in healthcare, and thirdly, bring to the table a few examples based and from different perspectives to the problem of humanism in healthcare in the Indian context. Firstly, let's go to the challenges. The modern healthcare system, especially that provided by the government, has continues to face two major challenges. One is intrinsic to biomedicine, which is an expert-centered of medicine, expert-based system of medicine, and it is the asymmetry in the knowledge between the doctor and the patient. It's because the patient has experiences the disease, is suffering from pain, and the doctor has knowledge of the disease and the expertise to cure it. So this asymmetry is there in any system of medicine, that the patient experiences the disease and the doctor has the expertise to cure it. Now, in biomedicine, it is particularly acute because it has become increasingly technology centered and highly advanced, highly specialized, where particular parts and subclinical entities within the body are being focused on, and the total person is being lost sight of. Secondly, also the lived experience of the patient and the patient's symptoms occupy less and less important space in the diagnostic process, which is largely based on numerical parameters of physiological processes or of images and other test results independent of the patient's symptoms. So, this could lead to a situation where the patient finds that his or her suffering or lived experience is not being heeded to by the doctor, who relies more on the technological inputs about the patient's body without paying attention to the experience of the patient. This is particularly acute if you look at end of life care in an ICU, which is highly medicalized. And so there's a lot of work on medicalization of death, where end of life patients are completely controlled in the ICU. They are cut off from loved ones and under the control of technology and medicine. Second problem is one of inequality. This inequality can lead to a gap in the socioeconomic status of medical care providers, which includes the physicians and also the paramedical staff and the patients. Generally, the people who seek healthcare from government facilities are people from resource poor backgrounds, women and children who might need help, vulnerable sections, migrants, people from indigenous communities, daily workers, etc., who would like to access free medical treatments. They are also the sections that suffer from dual burden of communicable and non communicable diseases. But the doctors and the medical staff come from stable socioeconomic backgrounds, and for them this process is sort of routinized. So this gap can lead to certain bureaucratic hurdles. They are of three kinds. Firstly, it can be direct and simple indifference or harshness towards the patients. This is often noted while people from other racial communities or members of indigenous communities, socially disprivileged communities, or simply poor background, they are treated harshly, not provided the required information. Or they at best might be treated in an indifferent way without dignity and respect. Secondly, the problem is sheer administrative regulations of the hospital, such as having to deposit money or having your documents, having should have had prenatal care to avail the delivery facilities. So, and that the patient should come from the same jurisdiction of the healthcare center, or they might be sent to another place. And in this transit, the patient may suffer or often even die. This happens very often in health centers, which send patients away saying that they should go to another district hospital. Thirdly, and most importantly, is the problem of social accessibility. This means that even if a government facility is physically available and also is economically accessible in providing free medical care of reasonably good quality, it is socially inaccessible because it involves lot of waiting time. Many good, high quality government facilities, even if they are present, are not sought after by daily wagers because going there and getting treated would involve losing a day's wages because the waiting time and the bureaucratic procedures are quite cumbersome, and they would rather go to a chemist shop or an unqualified practitioner and collect medicines. So this makes government facilities socially inaccessible also because of the huge burden of patients under outpatient care that they are treating. So these kind of issues lead to problems in health communication. Within philosophy of medicine, the focus, however, has not been on healthcare system or inequality. It has been more focused on the interpersonal relationship between the doctor and the patient. And in philosophy of medicine, the biological reductionism of biomedicine has been criticized. It has been pointed out that the doctor patient relationship is very cold, it is objectified. The patients, the technological sophistication tends to lose sight of the patient as a whole person, and there is a tendency to always be interested only in the disease and not in the patient as a person. And there is less of listening, and there is very less sensitivity to the socio-economic situation of the patient. There is very little empathy in this clinical encounter. These are the kind of criticisms that have been made, and the field of narrative medicine has emerged to bridge this gap, basically involving training doctors to listen and to themselves construct narratives of the doctor patient encounter. And this, the votaries of narrative medicine argue, has improved empathy, that is by making doctors write journals about their encounters with the patients and others, and make diary entries and discuss them has led to a situation where their empathy increases, their patience towards patient and listening to their narrative has improved. So such workshops continue to be conducted, and in the private sector, they have definitely led to a greater empathy and care to patients who can provide money. But our concern here is with the government health facilities. So we have to go beyond the interpersonal relationship between the doctor and the patient, which nevertheless has improved over the years. And but whether such condition inheres in the government health facility is something that we need to uh, be concerned with, because the interpersonal relationship is very important to ensure that the patient not just gets cured but also gets healed. This is one of the claims made by narrative medicine people, that the doctor should also heal. In this respect, I want to draw your attention to a very interesting study by an anthropologist, Daniel Moorman, in 2002, titled "Medicine, Meaning and Placebo Effect," where Moorman is looking at clinical trials and examining the control group in clinical trials that receives placebo. It's understandable that the experimental group gets cured and improves. But very often in the clinical trials, 40 to 60% of the participants in the control group who receive the placebo also get better without the medicine. So, how is this possible? Moorman called this meaning effect. He said that the whole idea of participating in the trial, being cared for, being attended to, receiving medicines, and being monitored actually brought about a positive effect, not just psychologically, but also had a physiological effect that improved the outcome of the treatment. So, this clearly shows that the meaning and the concern of the treatment matters in outcomes. And as the votaries of narrative medicine have pointed out, it is not only a moral necessity for the doctor to pay attention and show empathy to the patient, it also reduces neglect, it reduces error in treatment, and improves the outcomes of the curative treatment. While this is as it may be, I have to move to the third section and show how humanism in healthcare has to go beyond the interpersonal relationship between the doctor and the patient, especially in the healthcare bureaucracy. Because in private sector these benefits may be available, but is it available in the government sector? So I want to draw your attention to two experiments in the public health care delivery in India. One in the civil society sector to address the problem of inequality, and the second one to address the problem of asymmetry. Let me take the first one, the problem of socioeconomic status of the patients, especially vulnerable patients. Several initiatives to improve the access by involving community health workers have been done by the government facility. But what is important is that this is based only on vertical programs and specific reproductive health programs. Civil society initiatives are crucial to expand the horizon of public health care by going into the larger context of community problems such as nutrition, level of education, and so on. So, Jan Swasthya Sayog is a civil society organization started in 1996 by a group of highly qualified medical professionals from All India Institute of Medical Sciences. They felt that medicine should be directed to poor people who living in remote areas. So they felt that the biomedical knowledge is valuable, but the issue of humanism arises in the healthcare delivery, the way it is delivered to people. So they went to a remote area and set up a clinic, and in these 25 years, they have developed a full-fledged community outreach program which includes nutrition and education and a host of other problems in which the community is involved. And they have succeeded in providing low cost, high quality, community based healthcare. and have created a role model which could be replicated by the government sector. So innovations cannot be made fully from the government sector itself, which is ridden by bureaucratic hurdles. But civil society is a domain where innovations can be made. And one remarkable aspect of the Jan Swasthya Sahyog is that they have introduced appropriate technology in healthcare. A lot of medical technologies are expensive or inaccessible in resource poor areas. So, Jansastya Sayog has introduced the idea of appropriate technology by developing good quality testing kits using simple materials. So, they have a copper sulfate based anemia testing kit. They have developed first aid testing kits. They have developed breath counters. All these things using a simple cost effective material, and these testing kits are also available for distribution in other parts of the world. So appropriate technology, they could make biomedical care available to the poorest of poor people, and this set of altruistic set of people. So civil society can develop innovations is the point here. The second experiment I want to mention is that while the asymmetry in knowledge between the doctor and the patient that we started with can be addressed by better communication, patients, especially from resource poor background, should have the option of opting for holistic or other treatments which offer them a better effectivity. So, medical pluralism, which is a policy by which non-biomedical systems, alternative systems, and traditional medical systems are brought into the government healthcare and made available like biomedicine free of cost to the people, will be a huge step towards promoting humanism by way of giving them the choice to opt for curative care of biomedicine for certain ailments and opt for more holistic treatment for chronic ailments. This facility of medical pluralism is available in the private sector for the rich people. What I'm suggesting now is making it available in the public healthcare. And the government of India has created a separate ministry called the Ministry of Ayush, which is an acronym for Ayurveda, Unani, Yoga, Siddha, and Homeopathy, which are being offered in the government health services. Though there are several limitations in bringing in holistic systems within the health bureaucracy, that such that they might lose their holism. Nevertheless, these problems could be addressed, and medical pluralism as a policy will help address the problem of asymmetry better. So, I wish to conclude by pointing out that humanism in healthcare, especially in government healthcare, has to start with the interpersonal relationship between the doctor and patient, but has to extend to the health staff, paramedical staff who also have to be trained to provide humanistic care. And thirdly, extend to healthcare policy, bringing medical pluralism in, and to healthcare delivery, where civil society role models have to be imbibed in the government healthcare. Thank you.
Professor, thank you for your interesting presentation. Dear colleagues, our plenary session is coming to an end. We're a bit out of schedule, but our program will be according to plan. And now we have a technical break between the plenary session and the first section, just for 10 minutes. So be ready to join us soon. All sessions will be held as planned, and I remind you that this event is accredited, and all participants who attend all the events, the plenary session and the sections, will receive accreditation credits. So do not forget to confirm your presence with the corresponding button that appears on your screen. Well, I'm sure that it will be interesting for you to listen to our distinguished speakers and learn more about new technologies in the organization of sociological research. Thank you for your attention. The plenary session is over. We'll meet in 10 minutes. Sociology of Health, Modern Healthcare in Dialogue with Everyone.